Well, welcome everyone. Thanks for joining us today for the third in our series of webinars. We're glad to see everybody. I think we'll be having a few people join, but we have a lot of great content to cover today, so I want to get started on time. Presenting today is Sharman Figenshaw, who has been working on POLST issues for many, many years in Washington State and has been consulting with our Alaska POLST work group to help us develop our education. So she's going to be leading today's webinar along with a team of talented actors. So with that, I'll turn it over to you, Sharman.
Great, thank you, Jeannie, and thank you to all of you who are joining us for this third webinar on POLST. And today you'll see our topic is the art of communication, the long-term perspective with regard to POLST conversations. So, and you'll meet our talented team of actors in a few moments. Why is this not letting me advance? There we go. Some of them are on this slide. We want to thank again, once again, the long-term care subgroup of the DHSS POLST education work group. Dr. Karen Mailer, Barb Bigelow, thank you so much for helping us develop these slides and this presentation. And you'll be seeing Jeannie, Ursula, Marianne, and Hillary as we get into our role plays a little later. I want to give a shout out for the CMP grant funding that we have through the DHSS work and the Providence Alaska Foundation. Thank you for the partnership with ASHNA to put on these programs. While you all are looking at getting oriented, and I'm going to let you read a lot of the words on this goal sheet. Basically, today's goal is to look at conversation skills, to look at how high quality conversations actually lead to POLST forms that really do have the integrity of carrying someone's wishes so that they can be honored. Things that we have covered in previous webinars, like the mechanics of POLST, the difference between POLST and advanters, how the POLST form works, who are candidates for POLST we'll touch on a little today, but all of those mechanics about transitioning from Comfort 1 and also how POLST is used in acute care facilities. We are going to refer you back to the other webinars to catch that material. We will not be reviewing that here. So we'll be giving you a link to those tools at the end. We're going to start by just reviewing this one basic graphic. This is the graphic in the Alaska POLST brochure that really reminds us that POLST is part of this voluntary advanced care planning process, that really the core of that and what it's built on is this high fidelity conversation with people about their goals, values, and priorities. Only through that process do we end up with a form that really has good integrity. So we're going to see today a lot about how that works. There won't be a lot of, mechanics and details, but mostly we're going to be really digging into what does it mean to have these conversations. We're going to get to look at them. We're going to start by just reorienting ourselves. This is the Alaska POLST form. We want to remind ourselves that the POLST is basically a set of portable medical orders that can be taken action on in the field because they carry that level of active order set. They're meant for guiding emergency care. They're meant to be acted on and followed by EMS and other healthcare providers in any setting. And we're looking at who can be considered for POLST. I love to return to this because all of these criteria, not being surprised if people might die in the next few years, or all of those folks that might fall into that camp of being harmed or worsened by aggressive measures, we might see a preponderance of these kinds of folks in long-term care settings. So I think it's good as we take that lens that we're thinking about who could benefit. Also, people's personal values and preferences might make them a candidate for benefiting POLST, and to keep that in mind as well. So again, we're going to be focusing on that conversation. Even though we're focusing through the long-term care skill lens, These basic conversation skills that we're going to be showing can be used by anyone across the settings: primary care, specialty care, acute care, at many different levels. So we invite you, if you're not from a long-term care setting, to pay attention and to learn something and play with us a little bit. There'll be a chance for everyone to have a little bit of participation as we go. I'm going to start us out by introducing and having us meet a couple that we're going to get to know a little bit better today. So I'm going to set our path by sharing a little bit of the story behind Nicki and Joe. And we love to talk about how much story sets a context for people. So Nicki and Joe have been married 56 years. Joe was a teacher at the community college where Nicki started and was working in the library. She later studied education, also became a teacher. He went on to become dean of that small community college. Their kids they had 3 children. Their eldest is a financial planner, and their middle son, Dan, is a high school teacher. They live in a nearby major city, about an hour and a half away. Joan got her naturopathic degree. She's their youngest, and returned to their hometown and has a naturopathic practice. They enjoyed doing everything together. Joe is a gourmet cook, loved experimenting on his family with new recipes. Nicki was an avid gardener and taught her kids about medicinal plants. They loved to travel. When they retired, they remodeled a small house on the lake, and that's where they live. They're a little bit out of town now. It's a little more rustic. And they've been traveling, and it's during travels that Nicki noticed that Joe wasn't navigating as well as he normally would. His evaluation 8 years ago showed that he did have Alzheimer's dementia. And in the last couple of years, we'll see that that's progressed a bit. We'll learn a little bit more about their medical story in a few minutes. So as we look at conversations, there are several models out there that are widely available: Vital Talk, Respecting Choices, and then the one that we're using a lot in Washington right now, which is the Serious Illness Conversation Guide. But as we look at the high level of this, they all share these basic steps. And I'm just going to go through what these steps look like in a little bit more depth. While I do this, if you want to access the guide, we're going to be putting in the chat the link to the actual PDF for the Ariadne Serious Illness Conversation Guide. And that might be a useful thing to have handy as we go forward here. Again, it's just one of the tools that are available, but it's the one that I'll be using today for some of the scripting that you'll see. We want to remind ourselves that these conversations are not just for providers. Regardless of the role you have in healthcare, there's going to be questions that could be useful and that you're going to be able to see a way to help you in your role, help people with these conversations. Let's see, I skipped over. So very briefly, and I'm doing this because as we go into the role plays, I want you to all be listening for some of these words, some of these phrases. And so just briefly going through them, there's the introduction phrase. I'd like to talk with you about what's ahead. There's always an asking of permission. Is this okay? And as people push back a little bit, that normalizing of doing this for everyone so we can make sure we give you the best care. You'll see the step of just understanding. You may or may not see this in the role plays where people are reviewing what you know about the person's condition and then sharing, when it's appropriate, a prognosis. This is called mapping values, where we're exploring these key topics. These are the 6 that are in the Serious Illness Conversation Guide. There certainly are others. You may have a favorite one that you like to ask, but again, I put these there so we'll have a reference for what we're listening for in the role plays that are coming up. And then there's the closing statements, summarizing what you've heard people say, making a recommendation about what that next step might be, whether bringing in a family one or creating some orders or a list of things to talk about. Confirming and checking in, how does that sound? Did I miss anything? And then reassuring that we are really there to help support people. The other thing that I hope that you'll see in these role plays and want to be looking for and thinking about in terms of what makes this work. These are stressful conversations, and we talk about interstitial skills, this ability to align with intention, to respond to emotion is what you as the care provider are going to bring to this conversation so that that person can continue to feel safe and have the space they need to process and to move through. What we're looking for are those cues in the conversation that are going to give us a sense of what this person's goals are, so we'll know whether or not a POLST actually could benefit for them, and then what orders on the POLST would be consistent with what they want. So with that, we're going to learn a little bit more about what Nicki and Joe are up against right now. Nicki at 78 with a history of COPD and asthma, diabetes type 2, has recently been losing weight, has been stressed, and really a lot's on her shoulders with winter cubbing and the cabin being the way it is, and mostly with Joe's additional care. She became ill and was unable for her to get to medical care until she became so ill that she was not breathing well. Joe was able to call Joan, their daughter, who then called 911. And by the time they got there, Nicki was requiring intubation to help her breathe. She was in the hospital for 8 days total. 2 of those she was intubated. She responded really well to antibiotics. She's now ready to be discharged for rehab. Joe at 86, as we talked about, is Alzheimer's, dementia, mild hypertension, paroxysmal AFib. He is continent and verbal, but needing significant help with ADLs. The family has been looking for some time since Nicki was hospitalized a year or so ago at moving the couple to assisted living. They really have been setting that up. So this is the time now. And Joe will be moved into the apartment in the assisted living complex in the same campus as the skilled facility. So he'll be close by to Nicki. Now, as we're going to meet Joe and Joan as they meet with Hillary and are admitted into assisted living. So this is going to be a little bit tricky. We're going to bring back our actors. What I'm going to ask is everyone with your cameras off, if you go into the top right corner of your screen and hit the drop down and bring in a hide non-video participants. That way you'll really be seeing the bigger, just the actors on the screen. And meanwhile, oh, thank you for renaming me, Debbie, you did that. I'm going to be playing Joe, and Jeannie will be Joan, and Hillary will be on. So as many of you as possible, if you can hide non-video participants by finding those 3 dots in the right corner. Meanwhile, I think we can just get started. A little setup for this. You already know that Joe is coming. They're allowing him to stay because a granddaughter will be staying with him until Nicki is done with her rehab. Joe does not have an advance directive or a POLST. Hillary has been able to review Joe's medical records, knows about the dementia, but also knows that a diagnosis of dementia doesn't necessarily mean that all decision-making is gone. So she'll be looking at what decisions he'll be able to make. They've made introductions. They've gotten oriented. Hillary has already heard a little bit about Joe and Nicki's life history and story. And we'll start from there.
So thank you so much for sharing all that information, Joe. It sounds like you and Nicki have had some great adventures and share a lot of love. How are you feeling about being here?
Well, you know, we talked about this for a while. I've been kind of nervous. I really like our cabin, but it's what's best for Nicki, and whatever's best for Nicki is good with me. How is she? Can I go see her? Where's Nicki?
We'll go see her right after this, Dad. Thanks, Hillary. We're happy that you have a place for them and that you will let Dad stay here while Mom is recovering in rehab.
Absolutely. And we want to make this a place where you live your life, Joe, you and Nicki, the way that you want. We want to make sure that we know what's important to you so we can support you through this. Is it okay if I ask you some questions about what might help with that?
Sure, I hope I can answer them.
It's okay, Joe. I'd love for you to answer them as best you can. And Joan, feel free to jump in and help Joe if he needs help. So Joe, I wonder what feels important to you as you move into this new place?
Just Nicki, getting her better and being together with her. That's all I need is, I just need to be with Nicki.
That's right, Dad. As soon as Mom is done with therapy, she'll come and live with you in the apartment over here. Doesn't that sound nice? We just have to be patient. Mom's been through a lot right now.
I know, it's been scary seeing her so sick. I didn't like seeing all that they had to do to her.
That must have been really hard. I appreciate you sharing that, Joe, and that's important for us to know. So I wonder, what fears or worries do you have as you think about the future being here with Nicki?
Oh, I just worry about Nicki. She's just my rock. I worry that taking care of me is too much for her.
Dad, you are you're a rock yourself, and you might be a little bit of an old goat, but we know that you love Mom and that you want to do everything you can for her, just like she will for you.
Yeah, I can really see your concern for Nicki, Joe. She's very devoted to you and you to her as well. You're both lucky to have each other, and we want to make this easier for both of you. How does that sound?
Nice. I just don't want Nicki to get sick again. That was awful.
Yeah, so hard on both of you. And I wonder, as you think about what your wife went through, I'm curious, if you were that sick, would you be willing to go through what she went through?
Oh, I don't know. They were just all over her and with tubes and things. And I'm just glad it worked and that she's getting better. Can I go see her?
In just a few minutes. I want you to be able to see how close she's going to be with you. Would it be okay if I ask you just a few more questions?
Sure.
Okay, great. So Joe, if you think about if you were to get sick like Nicki, would you want to go through all that she went through?
Oh, I don't think so. I'm not like Nicki. You know, she's herself, and I'm just not so much anymore. Joni, what do you think?
Dad, that's right. You've said how you just want to be with Mom and that you don't want to be hooked up to machines, and that just can't help what's happening in your brain.
Yeah, that's right. No machines, no pounding on my heart. No, it just can't help me. You know, Nicki's my rock, but I'm like a stone.
Mm. You both have a big promise to take care of each other, and it's clear that you have talked about this with Joan and you know what your dad would want. Joan, that's really helpful. I think that it might be useful to get our nurse practitioner to come and see you about this. She can help you fill out some orders called a POLST that will help us all be able to honor your wishes, Joe. How does that sound?
Whatever you say.
Great. Let's go see Nicki.
Great. That sounds great, Joni. Let's go. Thank
All
you.
right. Thank you.
Okay. Now, we're going to take a minute and just debrief this. And I wonder if you think back on the way that we talked about some of those conversations, or if you're looking at the conversation guide. Actually, I am going to share my screen again because I'll get lost if I don't here. Okay, tricky. I'm going to ask everyone, did you hear Hillary be able to set the agenda for Joe and Joan? And what I want you to do is use the chat and see if you wrote down phrases or if you remember things that that were said that show you that she was really helping them understand what they were going to talk about. There was that time where she said, "We want to know what's important to you," and got him to say, "Okay," really ask permission. The other thing is exploring those values and those goals. Do any of you recall hearing what she said? You could put in the chat anything that you remember hearing. That was exploring the goals. I heard that she asked about fears and worries. Do y'all remember that? Yeah, and she asked, "What are you willing to go through?" She had to ask it a couple of times, but really framed it. And for Joe, I think what worked is that, yes, Marianne, thank you. For what fears or worries do you have? And then Jasmine, thank you. You asked what you'd be willing to go through this type of treatment. And because that situation had just happened and it had such emotional content for Joe, he was really able to relate to that, wasn't he? And then the end, her summary statement was really just an offering for the nurse practitioner to come back. She could hear that a pulse form would be great. Jean, thank you. I see how she gave the clear example of what Nicki went through if he would want something like that for himself. Yeah. So you can see how, even though this admissions person may or may not have, we don't know what her clinical background is, but here she's using these conversation skills to get at the decisions that Joe is able to make, especially in the context of having a caring and trusted advocate, his daughter Joan, right there. So commending the daughter for having these conversations with her parents and understanding their wishes. Yeah, thank you for your comments here. Yeah. So we're going to go back in now, and this time we're going to meet Nicki, who is going to be meeting with the nurse practitioner. Nicki and Joe have had a chance now to have a little time together. They've had a meal together, and now he's going off to get set up in his apartment. Marianne has reviewed Nicki's medical records and notices that she comes in with a POLST form. And Marianne, I think I'll let you set up what that POLST form, what are we going to do, a POLST form that says, I'm going to let you tell me what you want it to be saying. Okay.
So I think where we'll start is that we have what I received is a POLST form that has no CPR and no intubation.
And selective treatment.
Yeah,
okay.
And we're gonna talk a little bit more about that with
okay, great.
And her daughter.
So and we're gonna ask
Ursula
to come on. Ursula is going to be our Nicki, and Joan is who she is, and I will take my video off and let the actors start whenever they wish.
So you guys are all going to see why I'm a nurse practitioner, not an actress. So can you guys hear me okay? Okay. So hi, Nicki. It's so nice to see you. I don't know if you remember getting to meet me about a year ago, and thank you for meeting me virtually today. I appreciate it.
Sure, of course. I remember you. How's your dog?
You do remember me. She's old and decrepit, but she's really good. So I was able to look through, Joan, I was able to look through your chart, and Joan, I believe you're the daughter of Nicki, is that correct?
Yes. Yep.
Yep,
That's my mom.
It's so nice to meet you. And I think I saw your father, Nicki's husband, with your brother here also.
Yep, my brother Dan is helping my dad, Joe, get settled into his apartment in the other wing. It did him really good to come and see mom. It's been really hard on him not being with her, and I'm really glad it's working out for them to come here together.
Oh, I couldn't be happier for you and your family. I could understand this could be really hard.
Yeah.
So Nikki, I see that you've had another hospitalization. It was pretty tough. Tell me how you're feeling now.
Okay, I guess. I can tell the infection is better and I can breathe better again, though I feel like I have a long way to go to get my energy back.
That's understandable with what you've been through. I wonder if we could take just a minute to review the information that I received from the hospital. I'd really like to assure that we understand your preferences and what you want for your medical care so that we can take good care of you.
That's a good idea. I was a little foggy when they were going through it all before.
Most patients coming out of the hospital are. That's very understandable. Can we start with, I would love to gain your understanding, Nikki, of where you are at currently with your physical condition and what's going on with you medically currently.
Well, I know that I got so sick that the cold I had turned to pneumonia. And I've had pneumonia before, but not this bad. And I think I just let it go too long and didn't want to get help. But as I said, I'm very weak. And I think I need to face the fact that these bouts of pneumonia are really taking a toll on me.
Nikki, thank you for sharing that. I do think there's some, you're correct in your belief in what you're seeing. May I share part of what, may I expand on that a little bit and share some of my understanding of what's going on medically and where we're at?
Yeah, yes, please. I want to know what you know.
So as I stated, I do believe and I do worry that your body will continue to weaken. I hope at this juncture, though, that with support for as you're caring for your husband and caring for yourself, that you can get back to your previous baseline. And that you'll have, now that you have this support of our facility, that you can have more time and be able to enjoy your life. But as time progresses, it will get harder and harder to return to that prior baseline.
Well, it's hard to hear, but I'm not surprised. The whole point of this move here is understanding things are changing for both me and Joe. Isn't that right, Joni?
Yeah, that's right, Mom. We know the last couple of years have been really hard on you. And I'm so sorry, Mom, that we didn't get you more help sooner.
This is hard for most patients and families, Joni and Nikki. This is not an easy transition. And I know these are hard things to hear and talk about. I want to commend you for having these tough conversations. I'm so glad, Nikki, that you're here now and that we can support you and your husband to have a good life. But I wonder, as we look to your future with your health, what are your most important goals at this stage of life?
Well, to stay with Joe, he calls me his rock, and I think with someone else doing the cooking and the cleaning, we can just enjoy our time together. I want to learn new ways to spend time with him and enjoy each other as things change for him, with his dementia.
Your love for Joe is palpable. Thank you for sharing that. I wonder, what are your fears and your worries as you think about your future?
Well, I can't help worrying about getting so sick that I can't take care of Joe, or worse, like leaving him. He'd be heartbroken. I want to do everything I can to be strong for him, to be able to be there for him and spend time together.
Mom, you're such a trooper. You've done so much to take care of Dad. And now I hope that you will, with all this help, it should be easier for you to be able to enjoy time with Dad and not have it not be so hard.
I think that is a wonderful thing to hope for. I hope that with you both. So I wonder, Nikki, what gives you strength through all this? What helps you keep moving forward?
Well, definitely my family. Look at them, Joni, Dan, Carrie, everyone's taking care of the bills, and kids have been great. And Joe, yeah, even with his changes, he still makes me laugh.
Laughter is the best medicine, isn't it? So of course, you have a beautiful team. You've built a beautiful team with your husband. I wonder, going forward, what abilities are so critical to you that you would not want to live without them?
Well, like now that someone else can cook and clean and do all the chores, I think just being able to talk with Joe, be the one that understands him and to know him, to be there for him when he loses his way. If I wasn't able to do those things, there wouldn't be any point.
I understand. I got it. And if you get sicker, what are you willing to go through for the possibility of gaining more time?
Well, becoming a bit of an expert on that, aren't I? Yeah, it's not easy to say I want to go through that all again. It was hard, but I'm willing to go through it if doing that can really give me a chance to be back with Joe and recover like this time, and like the last. If it ever looked like I wasn't going to get back, to do these things, I wouldn't do all that just to be kept alive, though. That said, I mean, even now, if my heart were to stop, like we talked about in the hospital, I don't think I'd want any heroics at that point. I think that would not serve me or Joe very well. And I don't think I'd want that done. I think at that point, I'd say I'm done. Is that what the POLST form is about? I had one last year, but I think they made a new one for me in the hospital. I'm not sure I saw it after they did it, but we talked about it.
Yes, that is the
Yeah.
green form, or the POLST form is what we call that. And they actually had filled it out that you would not want CPR, or I believe that's what you mean by heroics, and that you also would not want intubation. As I listen to you, though, and hearing you, I think that we need to reconsider what this form is saying at this point. It sounds like what you want is, and what makes sense medically, is that you would not want CPR, but you would be okay if you had to go back in the ICU, if you had to be on a ventilator for a short time, as long as it looked like you would recover. Am I understanding that correctly?
Yeah, no, I think you have it right. I was so foggy and tired when they did that, but I do remember saying, I hope I never have to do that again. I do hope I never have to do that again, but I don't want it, but I would be willing to go through it if it could help, if it could work to help me recover again like this. So I think I was too tired to fully explain what I meant, but I think for how I'm feeling now and for what I've been through, I'm glad you asked about it.
And this is one of the important things that we do in healthcare, is reevaluate on a regular basis, especially at transitions when you're going from one facility to another, because we do make decisions at various times that we want to reconsider. So thank you for having the conversation, and we will get the POLST form filled out the way that you have voiced. I thank you again for having the conversation with us. And our facility is here to take care of you. We're all here to take care of you in the way that you want. And Joni, I'm so glad that you're here. Tell me, how are you feeling? Tell me what you're thinking about your mom's decision with this.
I think it makes total sense. We've talked about this a lot, and we know that mom and dad really want to be there for each other. And if dad weren't here, it might be different, but we totally support them doing whatever they can to be there for each other. We know mom has had to work really hard to recover, and we'll keep being there for dad. So we're going to be there for her however we can. So whatever she thinks, we support it.
It's really wonderful to see how your family comes together to support each other. This is a big move for all of you, not just Nicki and Joe. So what is going to happen as a nurse practitioner, I'm going to speak with your attending physician, Nicki, Dr. Sampson, and I'm going to finalize your POLST orders. And what they will read is no CPR if your heart stops, but you're accepting of full treatment, which could mean placement of a breathing tube and ICU level care as needed. Would you like to sign the form when I get it done? Just to and read the form so that you can see what I filled out?
Yes, yes. I think that would be a good idea. I would like to see the form and sign it.
All right then. What other questions or concerns do you have before I go help get this form completed?
No more questions. I just look forward to getting stronger. And thank you. Thank you for all your help in getting me situated here.
I'm happy to be a part of it.
Okay. So a little ovation for our actors, both on this script and the last one. Thank you so much, you guys. If as I start figuring out how to share my screen again, we're going to do the same thing. If everyone could just think about those things that they heard in the interaction. Let's start with, you know, how Marianne set up the agenda. How did she introduce the conversation? How did she, I'm going to go ahead and get people back on here. See if I can share my screen. And feel free to turn your cameras back on if you so choose. Let me see. Give me just a moment here. What we're going to do is come back into this and you'll see that I'm in not quite on the right screen, but I'll get us there soon here. All right. So using the chat again, did you hear the setting of the agenda, the asking permission? Were there phrases that told you that Marianne was assessing understanding? If you remember, there was that part where Marianne said, tell me what you understand. And they had the conversation about her lungs. I want to point out how Marianne really phrased that. She said, you know, yeah, Chad, thank you. MP was validating what Nicki and Joe were saying. There was a lot of nonverbal nodding and shaking yes, showing understanding. Also, how Marianne often ended with questions and asking about concerns. So thanks for that, for your comments. Notice how Marianne shared the news, if you will. We could call it the prognosis, but really framed it as, you know, I hope that you're going to be able to get better in return, but I worry that, you know, as time goes on, you're going to feel weaker. And that I hope, I worry statements are a great way to share news in a way that's a little less medical, and the hoping also helps us align with people. She explored those key topics about Nicki's worries, fears and worries, her strengths, asking what she'd be willing to go through. And there was that really nice moment where Nicki said, I'm becoming quite an expert at this, and really named her willingness to go through what she'd been through before, with the hope that she might survive it. So that was Marianne's clue that the POLST form that she was looking at wasn't really in alignment with Nicki's current wishes, and needed to have some work done. Lots of responding to emotion, with Marianne saying, it's great to see how you're coming together. I hear how much you love Joe. You have a great team. All those aligning statements, understanding, respecting statements are those ways that you're really responding to people's experience as they are moving through this kind of difficult conversation, but coming to some great decisions. And then did you all notice what Marianne did in the summary and the recommendations part? She named where there was a gap in what currently was existing and what she was hearing. and then confirmed with Nicki. It's sounding to me like you are going to want not only the DNR, but that you would be willing for the full treatment. Marian did a beautiful job of naming that means being willing to be intubated, being willing to be in the ICU, and then asking, did she get that right? And there was confirmation. So is that making some sense now? Just these steps can really help align these. I think that conversation took about 12 minutes. They're not necessarily lengthy hour-long conversations, but it really hits the high points and helps us know, is a POLST form going to help this person? I'm going to show you a couple of things now about starting with section B.
Oh, and sorry to interrupt, Charmin, you're in the notes. You're in the notes mode right now that's showing on the screen.
Oh, thank you so much. I'm going to stop sharing because that's not what I intended. Thank you. I appreciate that. And now that should fix it.
Perfect.
How's that?
Yep.
All
perfect.
right. Appreciate that. I would have not noticed that. Thanks so much. So as we look forward, as we think back onto that conversation, we realized that what happened was Nicki was able to talk about what would be important to her if she were sicker but alive. And that scenario was first. Like, yes, I'd be willing to be intubated. Yes, I'd be willing to go through what I did before. Based on her decisions then, she had already been pretty clear about her decision for CPR. But I'm going to show you in a minute how doing this first is then going to help you fill out section A. So instead of going from top to bottom on the form and filling it out like a checklist, if you can really focus on this section, starting with those section B orders, really dealing with someone imagining that they're sicker but still alive, what kind of care would they want? One of the things to notice is how the choices in section B actually line up with a location of care. So when you talk about someone who wants to have at least initial care aimed at longevity, aimed at doing all those aggressive treatments, what we would call full treatment, it's someone who's willing to go to the ICU. If you look at someone who says, yes, treat treatable conditions, discuss reasonable measures, but I would not want to end up on machines, that selective treatment choice means that they're willing to go to the hospital for basic care, but they'd like to avoid the ICU. And then the last section, or the last choice, the comfort measures, really means that people are more inclined to stay at home. So I love thinking about this in terms of location, because sometimes we really need to point the scenarios out to people. Let's imagine you get sicker. Where could you imagine, where would you be willing to have care? And that can help us really help people be able to picture how to make a choice for section B. And then as we circle back to section A, we're going to look at what that choice was that they made in section B was. And if it was full treatments, like with Nicki, Nicki is someone who could have said, yes, and I also want to have CPR. In this case, she said, I do want to draw the line there. I don't want CPR. But for anyone who's choosing, oops, I need to go back. The selective or comfort treatments, then their choice really, our job with them is to help them understand that not being willing to go to the ICU means that doing aggressive resuscitation would not be effective if we can't follow it up with good intensive care treatment. So those people, we're going to be helping them see that DNR is the right choice for them. If people push back and they say, no, I really want CPR, then we need to circle back around and say, well, then we really had best put full treatments in here. And if they want limits to full treatments beyond the initial emergency care they receive, that's the time to bring in the advanced directive and bring in those rich conversations with loved ones so that they'll know when to stop. And Nicki even alluded to that. If I wasn't recovering, if I was to just become a lump in the bed, then it wouldn't be worth it. Her daughter now is going to know, although mom's going to go initially for aggressive treatments, she's not going to want that to go on if they're not seeing her return to a reasonable state, to what she would call acceptable outcomes, right? A couple of other things to just have as resources is people will ask us, not everyone, but sometimes people will ask, what are my chances with CPR? And there are a lot of studies, they all basically come down to this chart, which was designed by Jerry Powell, saying that if you're looking at elderly patients, those 65 and older, and this was all the studies that looked at in-hospital resuscitation, about half people just don't survive the event. Another third of them will have complications, even if they initially were able to resume a heart rate. They're so sick that they are not going to be able to survive to discharge. Those that are discharged, another percentage of them will die in that immediate time after discharge. And of those that are still alive, of the 10 out of 100 that are still alive, almost all have significant neurological deficits. Added to this are the reviews that tell us that if patients are frail enough that they need to be in long-term care, then their chances of even surviving to that first month of discharge in a hospital drop to about 2%, a little under 2% actually. So that really is telling for all the folks that we care for in long-term care. If we look at them through this lens, we can help them understand what, and really make considerations for themselves of what they might benefit from. And here is a graph with some of the statistics about neurological function. It's, as you see, the best results are that about 13% of people under 70 will return to good neurological function. That leaves, 87% who won't. And as people get older, those percentages drop quite a bit for those who have good neurological function. And the percentage of people with poor neurological outcomes does increase. We're going to bring this back for a moment into the context of just the conversations and the planning that's done, and realizing this is being done in real time as people's lives and conditions are changing. So we talk about the 6 Ds as a place, as a way of remembering when it might be time to revise. This applies to advanced directives for people who are, healthy and living their lives independently. But I think the long-term care lens is that when you see those declines, if there's been a diagnosis, if there's been an admission, and perhaps the second D or another D could be discharged, they've been admitted and discharged from a hospital and they're back. If there's the death of a trusted advocate, a spouse or someone who's been speaking for them, that's another time to review and make sure you've got a current decision maker on board. And as people change settings, as often happens, people are moved to be closer to other trusted family members, then those plans need to be reviewed again. This information was in our other webinars, so I'm not going to look at it in depth, but again, especially when people lack an advance directive, it's important to remember that POLST form can be filled out by a surrogate. So it's really important to know who that surrogate is. And here's the decision-making hierarchy, which includes at the very top of it, someone who is named in an advance directive as a power of attorney for healthcare, but could also include someone designated to act as surrogate by the person verbally, as well as the rest of this hierarchy list of people who will be in that decision-making role. We need to remember that everyone in Alaska who works in a healthcare professional role, EMTs, first responders, providers and clinicians in all settings shall comply with POLST orders, must honor the completed POLST, and as a result, along with that comes protection from criminal liability, civil and criminal liability. So this does apply to all of our skilled and long-term care facilities. Consider advanced care planning for your healthcare facilities. Here are some things to consider. And for resources on those, we want to refer you back to the website. And we've got a few minutes now. I think I'll leave it on this slide while we open things up and invite people to ask questions verbally, put things in the chat. I don't see any questions currently. If you want to turn your mics back on, feel free to ask a question.
Charmin speaking about the surrogate tree and knowing who would serve as decision maker if they don't have a power of attorney for that. I think it's also important to emphasize the importance of, even when that patient has decision-making capacity, encouraging a conversation with family or the person mainly that would be making the decisions if that patient became unable to. It's the best way to assure that we honor and respect what the patient wants and making sure that the whole family's aligned so there isn't distress.
Yeah, such a good point, Marianne. And I remember we did a project, Hillary was involved in this in a nursing home where in doing some research, we uncovered some studies saying that even under normal stress of, someone who's fairly normal, fairly healthy and good decision-making, that they are 73% more likely to make better decisions and feel better about their decisions if they are supported in that with trusted loved ones when they're going through stress. So any of us at any time when we're in a hospital are going to do a better job of engaging in these conversations if our loved ones are there to support us in them. So it's an important thing to bring out. I want to point out that on this website, you can find the links here to the videos and recordings. Let me get this out of the way. There's some clinician FAQs about POLST. There's the POLST program guide, as well as the access to the form. And this will also be the site that, as more resources become available, these will be posted here. Currently, there is a link to another state that has the policies that they have around POLST for long-term care are posted there as a sample for people to use, perhaps as a template or some to get ideas for doing policy work. Other questions? Anything we missed to my talented team of actors? Any other points that would be good to bring out? I hope that you're able to see how important it is to just be engaging with people with a few simple questions to be able to really elicit their values and really guide a very informed POLST so that it can really be the tool that they can count on to support their wishes.
Since we do have a little bit of time left, I do have a question I want to pose. And this is the third in our series of 3 webinars. However, we know that this is not the end of the education and support that's needed. So I would be interested in hearing from those attending today, what additional topics are you interested in further education? And what would be most helpful to all of you as the POLST implementation moves forward? And feel free to share them, take yourself off mute and share it, or just put it in the chat.
Great point. Thanks for bringing that up, Jeannie. I think that as the entire state embarks on this journey with POLST, it'll be great to be hearing from everyone about what you're encountering and what you feel that you need help with. I also know that with the last webinar, we invited those of you who might be willing and interested to be in contact with the long-term care work group. And if you'd like to participate at all, they can help welcome you on board and take your input into that team as well.
I'll also add a little bit of information about what's coming for patient and family education on this website. So there is a page that links from akpulse.org that'll have specific patient family resources, including videos on CPR, POLST, advanced care planning, goals of care, and some resource guides. And the POLST program brochure that would be nice to give to patients with the POLST that explains what it is and kind of what to do with it and how it works is will also be available on the clinician resource tab. And then there's more patient resources coming out around a contemplative guide that patients or families can review before having a POLST conversation, and also what does your completed POLST mean for to give after the conversation if indicated. And DHSS is working on translations of the POLST form and the patient brochure for the most common languages represented in Alaska. And when those are available, they'll be found on this website as well. For translations, you would always complete the English form because that's what healthcare professionals need to follow, but you could keep with it a translated form in the patient family language. Thanks.
Yeah, that is very exciting news, Ursula. We in Washington, we just got our translations done last year. It's a very immense service to be able to offer to families, to be able to have the form in their native language, whatever that may be. Thank you for pointing out, though, that the English version will always accompany that so that it can be followed. Great.
Well, I would encourage any of you to reach out to us at ASHNA, particularly if you work for a long-term care facility. You should know how to reach us, myself at ASHNA or Connie Beamer, and let us know how you're doing, your education needs, any materials that would be helpful to you. We really want to support you.
Great. And Jeannie knows how to get a hold of all of us as well. If you have any questions of anyone on the team or on the panel or myself, yeah, please feel free to direct questions to us.
Great. Well, thanks everyone for your time today. And if there's no last minute questions, we appreciate you taking the time to learn and to listen, and look forward to future webinars.
Great. Thanks, everyone.
Thanks. As you all leave, we're going to continue the recordings just to read through the chat for when we post the recorded webinar, since that's not included in the video that's recorded. But there was only 2 questions, so it'll be quick. I'll go through one, 2 as people leave. Thanks for joining.
Thanks. Sorry, Ursula, I forgot about that. So I'm glad you remembered.
It wasn't an active, not an active chat, but we had one question about how does EMS get the POLST, and that is worth describing because very often Comfort One was kept on file at dispatch. So when a patient called 911 or someone called for a patient and they said they had a Comfort One, it was able to be validated at the level of dispatch. And now, but at that time, the form always meant the same thing, whereas POLST has medical orders that is more than just having a pulse. You need to know what's on the POLST, and there really wasn't a way to reproduce that and do that the same way as Comfort One. And so it is not going to be that Comfort One is routinely recommended to be held at the local dispatch. And there might need to be some local implementation around kind of how that's done that fits individual environments. But for communities that have local hospitals, it's recommended that the POLST be on file at the local hospital so that if EMS was called and the patient didn't have the POLST, that they could call the local hospital or their med control to look up the POLST on file at the hospital. But you can understand that this is a big change, and we need to do a lot of education for patient, family, or facility to know where the POLST is and to present it anytime EMS arrives. And EMS isn't going to know necessarily their wishes until arrival and reviewing the POLST form. There is hope and plans to have a registry, an electronic registry, where the POLST orders could be part of the ED system that communicates information to EMS and emergency personnel, and that you could then access, if you're a healthcare professional with access to this ED system, you would have access to patients' POLSTs all across Alaska. So that would be best practice. But all states figure out how to do this with paper by empowering patients and families to present them. So that would also be true for long-term care and skilled nursing facilities, that upon calling EMS, that they're able to present the form. And then there was one direct question that wasn't posted about, so do we do Comfort One and POLST? And it's worth just highlighting in this transition time, both Comfort One and POLST will be honored. So when presented, a healthcare professional should know and be able to honor a patient's previously done POLST or Comfort One. And now it's recommended to start using POLST, but you may still complete Comfort Ones at this time as you adapt your practice to POLST, but you only need one or the other. And if you can do POLST now, it's recommended to do POLST now. DHSS is going to stop resupplying Comfort Ones in June 2022. So the supply of Comfort Ones will end, and that will force the use of POLST moving forward. But we're not going to be able to get every Comfort One out there and update it to a POLST. And so it is expected, and EMS will continue training to know what a Comfort One is. And as such, hospitals or nursing homes, when presented, long-term care facilities, when presented Comfort Ones, would need to know what that was. And then, but it is recommended to update them to POLST if possible. The POLST is voluntary. So if someone has a Comfort One and they don't want to update to a POLST, then they don't have to, and we'll honor the Comfort One. And those were the two questions.
That's great. Really good information. I know that as more and more POLSTs are out there, as we were talking in our subgroup, you're going to see more and more people with POLST than might have had a Comfort One, because Comfort One was really just for that that instance of terminal diagnosis, and POLST really has a little bit broader scope. So I think it'll be a great transition for folks to see how many more people can be benefited by it. So again, thanks everyone so much. Thanks for all the support of this great team.
Thanks. Bye-bye, everyone.
Julie and your staff.
Thank you.
Take care.